Should I start with what I was brought in to do?
Yes.
Yes. Because things have changed a little bit, or added. So what I was brought in to do, first of all, is do several things. First of all, be the advocate for all of the psychiatrists. And my way of thinking is I'm not just acting as a blind advocate. I'm acting in a way that mentors psychiatrists and lets them know really how I feel about doing things, what's the right way to do things, help them improve their level of wisdom, their ability to establish good therapeutic bonds with patients, and their ability to support the recovery model, something I'm very passionate about. And all my other colleagues in the Office of Discipline Chiefs are very passionate about recovery. So an advocate for the psychiatrist. I'm there whenever they need me. They all have my cell phone. They can call me 24 hours a day. They don't call me enough. They always say, I don't want to bother you. But that's my role, is to be there for them. I was also brought in to really establish a fantastic recruitment program in order to fill these vacant spots that we have in DMH. Everybody thinks of it as somewhat of a crisis, that we don't have enough psychiatrists. Well, I'm trying to do what I can in order to improve that. Some of the things that I'm looking at, I've been participating in every single conference that psychiatrists have across the state and outside of the state in order to just stand there by the DMH booth and recruit as much as I possibly can. I feel like I've gotten some traction. I've tried to work really hard with the team to reduce the onboarding time for psychiatrists. I've been instituting a really robust telehealth program for psychiatrists so that they can call in from anywhere and pipe into the clinics that are traditionally extremely hard to fill. The mission alone just isn't enough to get people to work an hour, 2 hours, 3 hours away from where they live. And I realize that, and we have to be practical about it. So telehealth will be the great equalizer for that. They'll be able to call in from any clinic, call in from home, and provide every type of service necessary for patient care and for team advancement. They will be calling into these clinics. They will be part of the clinic team. They won't be part of the telehealth hub. And they will do everything they do that other people that work in the clinics do. And I think that's really going to be the great equalizer. Great equalizer meaning that we'll get as many people at Antelope Valley, I hope, as we get at Edelman, right? Or downtown mental health, for that matter. So I'm hoping that that's really going to be a game changer for us. We just established a new registry that will start July 1st, or maybe a little bit after, where our own staff will be able to do extra shifts in the clinics. You know, for us, there's a lot of people who are doing 410s in a week, and they have that extra fifth day. If they want to do extra work moonlighting, they can basically do moonlighting in-house. And that means they could even work in the very clinic that they work the other 4 days, and it's a seamless approach. They get a little extra money. They don't have to look out elsewhere to get credentialed other places. They're already credentialed with DMH. And I really think this is one of the main game changers, even more than the loan repayment program, which we have now too. So we also offer loan repayment. As you know, psychiatrists, doctors in general have massive loans when they get out of their training programs, medical school, and upwards of several $100,000. So we have a loan repayment program going on right now, where they get upwards of $250,000 over 5 years. It's the most flexible loan repayment program I've seen in the country, because you can do 1 year just for $50,000, 2 years for $100,000. You can leave it if you don't like it, and you still get that initial money. So it's a pretty good program. I'm also trying to help our psychiatrists who are coming into the system develop positions which are really sustainable, something that's really going to spike their interests, something that they can help improve systems and not just individual patients, because that's what all our new people coming out of residencies want to do. There's a massive move right now, for whatever reason, towards public health. Even the very best residency programs like UCLA I used to work at UCLA, I used to be on the faculty there, and I remember when I was there, every single resident, even those in the research tracks, would leave the residency with a full private practice, they'd go on their private side, and they would never come back. Now our residents at UCLA are very invested in public health, they're all coming our way. So this is a wave, I don't know how long it's gonna last, but I wanna really grab it, because this is a wonderful time. They wanna work in public health, they wanna help change systems. As you all know, we have a lot of things that we can improve on in DMH. And so it's pretty enticing when I offer it to them. I say, you can change it, it's not lip service. You can change our system. Even as a resident, you can come in and really do something that will change the entire DMH as we know it. And it's actually true. So they're all invested, they're all gonna be doing electives, they're all coming in. What else for that? Well, I'll move into, after recruitment, something else that we're doing, or something else I'm doing. I'm also really involved in training, residency education. So I am the chief representative for all of the universities' psychiatric training programs. I go out to all of the training programs across the town and try to recruit them into DMH. And so far, I think we've got a lot of interest in that, and I think we'll see a big push once this residency year finishes, once people start looking for real jobs after they finally complete training. So around July, August, I think we'll see a large influx of psychiatrists and really dedicated people that are really excited about it. So I participate in the training. As you may not know, but we support 2 different residency programs right now. We support the whole Charles Drew psychiatric residency program. We financially support it, and we support it with training. Also, half of the All of You Medical Center training program. And this is going to grow over time. And the goal of this is, obviously, is